Hello, everyone, and welcome to the December 2024 Registry Partners Oncology Coding Break. Today's topic is Hematopoietic Malignancies, a comprehensive synopsis. My name is Heather Donahue, and I will be your presenter today. So in today's presentation, we'll be taking a look at the bone marrow anatomy. So this is really important in understanding heme diseases. So we'll differentiate between yellow and red marrow and take a look at cellular production, starting with stem cells, blast cells, and then mature cells. We'll take a look at myeloproliferative neoplasms, which are diseases of the mature cells. And specifically today, we're going to take a look at PV, ET, and CML. And then we'll also take a look at some acute leukemias. So these are diseases of the immature cells. And today we're going to focus on ALL and AML. So this slide here is a glossary of terms and definitions. So these are all terms you'll see throughout the presentation, but you'll also be seeing these terms in your pathology reports, your physician notes, or even in imaging. Let's say, for example, splenic infarcts. So you might see this dictated by a physician and wonder exactly what that is, or even see it most likely in your imaging reports. So this is tissue death caused by a compromised or blocked blood supply in the spleen as a result of thrombosis. And so you could see this in Polycythemia vera or ET. And this is a good list to keep handy, just when you're navigating your cases and you're reading through your reports. So half the battle is really just understanding what you're reading in those reports. And once you get that down, things become a lot easier with these heme cases. So let's start by looking at the bone marrow. So the bone marrow is made up of compact bone, spongy bone, and bone marrow. So the compact bone makes up the outer layer of the bone. Spongy bone is found mostly at the ends of the bones and contains the red marrow in the core of the bone. So keep in mind, myelo means core or marrow. There's two types of bone marrow, as I just discussed. So we have red and yellow. Yellow is made up of mostly adipose and fat tissue. Red marrow is the hematopoietic marrow, so meaning blood cell producing. It contains blood stem cells that can become red blood cells, white blood cells, or platelets. So if we take a closer look at the stem cells, we have a myeloid lineage and a lymphoid lineage. So lymphoid stem cells become lymphoblasts and then mature B or T lymphocytes and natural killer cells, which are white blood cells. Myeloid stem cells become either mature red blood cells, mature platelets, or myeloblasts. These myeloblasts then become one of three types of mature granulocytes. So we have neutrophils, eosinophils, and basophils. These white blood cells contain granules that are released to help fight off infection and disease. So with that, we can start by looking at myeloproliferative neoplasms. So again, myelo meaning bone marrow, and proliferative meaning multiplying at a rapid rate. So we have Polycythemia vera. These are all tongue twisters and a mouthful, so excuse me up front if I have to say things a few times. So let's start again. Polycythemia vera, essential thrombocythemia, primary myelofibrosis, chronic myelogenous leukemia, chronic neutrophilic leukemia, and chronic eosinophilic leukemia. So these neoplasms come from the myeloid lineage, and you can see I blurred out the lymphoid lineage to the right just for right now. So we're going to focus right over here on the myeloid lineage. So in myeloproliferative neoplasms, the marrow becomes hypercellular with panmyelosis, meaning there is an increase in all myeloid blood cells and all MPNs. So when red blood cells are the main myeloproliferative cells, this is Polycythemia vera. We have essential thrombocythemia when there are too many megakaryocytes. This cell is the origin of platelets. So platelets are actually pieces of megakaryocytes. So ET is associated, we know that with too many platelets in the blood, but these platelets come from megakaryocytes. We'll talk a little bit more about that in an upcoming slide. And then when there's basophilia, this is CML. Neutrophilia, this is CNL. And when there's eosinophilia, this is CEL. So how do we know when there is a myeloid or a lymphoid neoplasm? So symptomatic patients will have a CBC as part of their initial workup to evaluate blood counts to see if there is anything abnormal that might point to infection, blood loss, or even neoplasms or other heme disorders. Asymptomatic patients might have a CBC drawn as part of routine blood work or in an annual, or follow-up exams. Abnormalities seen within the CBC will then prompt a peripheral blood smear. So in CBC, we get the information about how many cells are present in the circulating blood, but with a peripheral blood smear, the cells can be looked at under a microscope and additional information on the shape, size, and appearance of the cells can be obtained. So abnormal peripheral blood smears typically prompt a bone marrow biopsy to evaluate cellularity in the bone marrow. So looking for hypo or hypercellularity, so cytosis or cytopenia, cytosis meaning too many, so hypercellularity, or cytopenia, hypo, too few. So looking for number of blasts or immature cells, so too many immature blood cells are usually indicative of cancer such as an AML. Looking for looking at the number of mature cells, so too many mature blood cells is usually indicative of those chronic diseases, so something like CML. So looking for dysplasias or morphologic abnormalities, so megakaryocyte dysplasia is indicative of MPNs and MDS. Looking at the plasma cell, so increased number can be indicative of multiple myeloma. Looking at cellular distribution, so clustering and clumping of megakaryocytes can be indicative of primary myelofibrosis, essential thrombocythemia, and polycythemia vera. Increased mast cells in the marrow are observed in conditions such as aplastic anemia, CLL, hairy cell leukemia, and impending blast crisis in chronic myeloid leukemia, which we'll talk about coming up, and also systemic mastocytosis, mast cell sarcoma, and lymphoplasmacytic lymphoma. So let's start by taking a look at polycythemia vera. In PV, there's a panmyelosis, so an increase in all cells. So all of the cell lines are affected, but in PV, there's especially an increase in red blood cell production, independent of mechanisms that normally regulate erythropoiesis. So erythropoiesis meaning the production of red blood cells. So some signs and symptoms include DVTs, an increased H&H, increased white blood cells, low erythropoietin EPO level, which we'll talk about in a few minutes when we talk about JAK2, headaches, hypertension, itching, splenomegaly, weakness, unintentional weight loss, these type of things. We'll be taking a closer look at diagnostic criteria, but for right now, at a minimum, there is a CBC and peripheral blood smear, and typically a bone marrow biopsy with some genetic testing done. We'll also see the EPO level drawn many times, not always, but many times we'll see that as well. And definitive diagnostic methods include evaluating the bone marrow and looking at genetics. So JAK2 mutation is positive in nearly all PV patients, and what tells physicians that this is not another disease such as CML is the absence of the Philadelphia chromosome or the BCR-ABL1 fusion. In PV cases, we'll be looking for the JAK2 mutation, so what I just talked about. But what exactly is that JAK2 mutation? So here's a little bit of background. The mutation is kind of like the ringleader of cellular production of myeloproliferative cells. So it provides instructions for production of a protein that signals and promotes the growth or proliferation of cells. So the JAK2 protein is particularly important in controlling the production of red blood cells, white blood cells, and platelets. So in PV, the JAK2 mutation, commonly the V617F mutation, will lead to overstimulation of the erythropoietin, so red blood cell producing, receptors in the marrow, causing an increase in red blood cell production. And now with that, there's too many red blood cells. So because of this, the body will not secrete or will drastically slow down the secretion of erythropoietin hormone, EPO, that usually stimulates those new red blood cells to be made. And why? Because the body is amazing and recognizes that there are already far too many red blood cells. So just to reiterate, JAK2 overstimulates, so JAK2 mutation overstimulates erythropoietin receptors. Now we have far too many red blood cells circulating. So the body shuts down the way that we normally make those red blood cells, causing the EPO level to be low. And then here we have polycythemia vera. So, really important here to note is that polycythemia alone, or stated to be secondary or relative, is not reportable. You must have that word vera, which means true in Latin. So true PV is primary and due to what we just discussed. And the JAK2 mutation is in almost all of these patients causing the overstimulation of those erythrocyte receptors. So false or relative is usually a loss in plasma volume in the sample, making the crit appear high. Secondary is usually a response to hypoxia due to things like COPD, high altitude smoking, CO2 poisoning, or even RCC, HCC, and hemangioblastoma. So again, relative and secondary polycythemia is not cancer, not reportable. It has to be polycythemia vera. So taking a quick look here at staging, the beauty here with these cases is AJCC, we don't have to worry about anything there. It's all not applicable. Same with seer summary stage, it's applicable, but these are always going to be distant by nature. And your EOD of the primary tumor is always going to be 700, and then lymph nodes and Mets are just not applicable. And then we have our SSDI for JAK2. Again, the most common mutation for PV is V617F. That would be code 1, but if you had something other than that, we have codes for that as well. The treatment is phlebotomy is common. So they're going to do the phlebotomy on these patients until the crit normalizes. And it's really important that this is captured and coded under other therapy, code 1. A lot of times this is overlooked and the phlebotomy isn't captured at all in these cases. It's really important to know to be looking out for these phlebotomies in these PV patients and to get them captured and coded and in your text as well. Chemotherapy with hydroxyurea is also common. And then for high-risk patients, we might see immunotherapy. Another note I do have here is most of these patients will also be on aspirin. For PV, aspirin is not coded as therapy. Now, for some of us that have been doing this for quite a few years, we used to code aspirin for PV, and then we found out that that was incorrect. And they said, oh, halt that. We don't want to code aspirin for PV. So we have to remember that if we've already trained our brains that aspirin is coded for PV, we have to untrain our brains and leave the aspirin alone when it comes to polycythemia vera. So what we're looking for that is a different, unusual type of treatment for PV is the phlebotomy. And then, of course, systemic therapy is also a possibility. Always make sure that you are consulting the heme database as well. This tool is phenomenal. It's so helpful. It's here to help us navigate these cases. So as you can see, there's some background information on PV as well as diagnostic criteria. And the diagnosis does require integration of clinical labs and bone marrow biopsy. So in order to have a diagnosis of PV, 3 major criteria must be met, or 2 major criteria and 1 minor criteria. And we'll take a closer look at that in a minute. You also, again, want to be checking for that JAK2 mutation. So when there's high levels of red blood cells and platelets, always look for that JAK2 mutation. And here's a pro tip for you. In your EMR, if you have a chart search feature, which most do these days, an efficiency tip, pop in JAK2, and you should probably get hits on physicians dictating the JAK2 mutation as well as genetic reports. So let's take a look here at what a PV case might look like. So this is a 39-year-old Black male, recent history of acute myocardial infarction requiring stent placement. The labs were abnormal with red blood cell, crit, and platelets all high. They did genetic testing, and he did in fact have the JAK2 V617F mutation. The patient's physician says that PV and ET are two of the most frequent MPNs. He goes on to list the WHO diagnostic criteria for PV. Major criteria, hemoglobin greater than 16.5 or crit greater than 49% in men. And this patient does have a crit of 55%, which is high. So we're looking here. And the presence of JAK2 mutation. So again, here we are. That criteria has been met. And now he needs a bone marrow biopsy to assess whether there is panmyelosis, so an increase in all of those cell types with pleomorphic mature megakaryocytes, or another minor criteria would be a subnormal serum EPO level. So we talked about that. That could also lead to diagnosis of this patient. But the physician does say that he suspects PV based on criteria 1 and 2, but needs to proceed with the bone marrow biopsy. So he does the bone marrow biopsy. Oh, I see that my screen is a little bit delayed here. Sorry about that. They do the bone marrow biopsy, and the myeloid lineage exhibits progressive maturation, as does the erythroid lineage. Megakaryocytes are increased and pleomorphic, so having variation in size and shape of the nuclei. And the interpretation is MPN consistent with Polycythemia vera. Primary site is always C42.1. Histology is 9950/3. And the confirmation is 3 due to JAK2 mutation. So that's important too. Make sure that you are capturing your confirmation as 3 when you have positive genetics as well. This patient went on to have phlebotomies until his crit normalized, and again, coded under other therapy, code 1. And then he also had hydrea to reduce the red blood cells and the platelets, which is coded as chemotherapy, code 02. Now let's switch gears and we'll talk a little bit about ET. So this is an MPN, so we'll still be looking at that myeloid lineage. And this disease is marked by high levels of platelets. So let's take a look at where those platelets actually come from. So you heard earlier that the origin of platelets is the megakaryocyte. So megakaryocytes start as a stem cell and then become a megakaryoblast and then a megakaryocyte. They get their name from the size being big, so hence mega, karyo meaning nucleus, and cyte meaning cell. So we have a really big mega cell with a single nucleus, and that nucleus actually has, and that cell has multiple lobes. So what's interesting about these cells is that they don't divide, but rather replicate DNA within the same cell. So that's why it gets so big. These cells range from 20 to 100 micrometers and are 10 to 15 times larger than red blood cells. So that gives you an idea of how big they are. So where do these platelets come in then? What do they have to do with megakaryocytes? All right, well, these megakaryocytes are so big that when they squeeze through the bone marrow capillaries and into the bloodstream, they kind of explode and become thousands and thousands of these tiny sticky little platelets, which are not cells, but rather pieces of the megakaryocyte membrane and cytoplasm. So platelets have no nucleus and no ability to divide. They're pieces from that megakaryocyte explosion. So ET, also an MPN, as we discussed, characterized by an increase in platelets in the peripheral blood and hypercellular marrow. Abnormal or clustered megakaryocytes in the bone marrow are also usually seen, and the median age for this disease is 50 to 60 years old. Just like PV, with ET, all cell lines are affected, but with ET, we're going to see that increase in platelets. So that's where we're going to see the most effect. So ET is also typically accompanied by leukocytosis and erythrocytosis, as well as other signs and symptoms. So bruising, redness, or burning and tingling of the hands and feet, GI bleeds, headaches, splenomegaly can happen. Like I noted in PV, it's a little rare here in ET. Thrombosis is obviously a big one, being that there are far too many of those sticky little platelets circulating around. So diagnosis is really one of exclusion of other MPNs. It does require clinical assessment, CBC and bone marrow biopsy. So CBC and peripheral blood will be evaluated. Genetics will be looked at. So they're going to look for JAK2 mutation, but also CALR, MPL, and the MPL are all common. So most common, again, JAK2, but CALR or MPL are also possible. And then, again, they're going to look to exclude other neoplasms. So they're also going to look for that BCR-ABL1 fusion to be absent as well. Iron deficiency, so that could be caused by, that could be other secondary causes of thrombocytosis. So we need to be on the lookout for that. So those would be iron deficiency, infection, splenectomy, trauma, surgery, or ischemia. So again, we want to be able to rule out other causes besides neoplasm. And our definitive diagnostic methods, so we're looking for bone marrow showing hypercellularity with megakaryocyte hypertrophy and hyperplasia. And again, genetic testing ruling out CML with that Philadelphia chromosome being absent, and the JAK2 mutation is a possibility as well as those other mutations there. So based on what we just learned, we now know that we'll never, ever, ever see platelets in a bone marrow sample. Instead, we'll be looking for megakaryocytes in the bone marrow, and then we'll be looking for the platelets in the peripheral blood smear. Staging and SSCIs are the same for ET as we saw for PV. ET is treated with low-dose aspirin, so less than 100 milligrams a day, and this should be coded. So PV, no, we do not code it. ET, yes, we do code it. So you want to keep that straight, and you want to make sure, again, that you're not overlooking the aspirin and that is being coded for these cases. Patients are also usually treated with anagrelide. This is also coded under other therapy for ET. ET patients can also have chemotherapy, again with hydria or hydroxyurea, and high-risk patients can also have that immunotherapy as well. So taking a look at what an ET case might look like, this patient is a 66-year-old white female who presented with abdominal pain. CT was ordered, showing multiple wedge-shaped hypodense lesions in the periphery of the spleen, likely representing splenic infarcts, which is when the spleen blood supply is blocked. We talked about that on one of the first slides there, but just as a reminder. So that causes some tissue death. And this is something that we might see in these ET patients. So you want to keep an eye out for that. And then the patient had labs drawn that were abnormal, prompting a peripheral blood smear, revealing thrombocytosis with an extremely high platelet count of 741,000. Bone marrow biopsy was ordered and pointed us to an important comment. The comment stated that the marrow showed mildly left-shifted myelopoiesis with increased eosinophils. Myeloproliferative neoplasm was the diagnosis, with ET strongly favored, but they needed flow and cytogenetics before a final diagnosis. On flow, CD61 was positive, indicating an increase in megakaryocytes. Cytogenetics, BCR and ABL1 fusion was negative. JAK2V16F was positive. The final path diagnosis was MPN consistent with ET. The physician states that the patient does not meet criteria for other MPNs. Looking at the major criteria for diagnosis, the patient met all four. So the platelet count was greater than 450,000. The bone marrow biopsy showing an increase in megakaryocytes, which was proven by CD61 positivity, did not meet the criteria for other MDS or MPNs, and did have the JAK2 positivity. So the primary site is C42.1, the histology is 9962/3, and the confirmation is 3 due to CD61 and JAK2 positivity. The patient was treated with hydrea, chemotherapy, and aspirin, which is other therapy. Again, so don't forget to code that aspirin, that's really important, and capture that in your text as well. So here I just wanted to give a side-by-side comparison because as you can see, PV and ET can look very similar. And so this slide is just to show you the similarities and then their differences. So I won't go through everything here. We just talked about most of it, but ET and PV will both have hypercellular marrow in all cell lines. Both can have that JAK2 mutation, and most of the time they will have that JAK2 mutation, both ET and PV. But more common in PV again with 99% of patients versus ET. These patients, it's more 50 to 60% of the time they'll have that JAK2 mutation. Both will always be negative for that BCR ABL1 fusion that will be ruling out CML, and both can transform to AML and myelofibrosis. So the major differences is the increased red blood cells versus the platelets on peripheral blood or the megakaryocytes on bone marrow biopsy. So you can review this after the presentation or when you're going back through the slides to look again at how they are very much similar and then where their differences are. But I just wanted to show you that there. Okay, we're going to move along to chronic myeloid leukemia. Okay, so what is CML? Chronic meaning mature cells, myeloid of the myeloid lineage, so neutrophils, basophils, eosinophils, leukemia, malignancy arising from monoclonal stem cells. So this is one cell that is acting up and causing the entire line to clone the same way. So whenever you see that, that's what that means. Altogether, CML is a chronic disease of the mature cells with dysfunctional mature myeloid granulocytes. We have the main umbrella category for CML, which is 9863/3. That is just an NOS category. This histology is only allowable on DCO and path-only cases. This is a generic code and only used when there is no genetic testing. And they usually say this is only really allowable, again, on those DCO and path-only cases. This could also be the case on, let's say, a patient who is elderly, like 94 years old. They're suspecting that there's something going on, some kind of MPN. They can see that it's a CML, but they're not going to do any further testing. And so that could be another one of those scenarios where they don't continue with any workup or anything. The patient is just going to have comfort care, and that's that. So that could be another time where it would be acceptable to have CML NOS if there's no genetic testing done. But otherwise, all other cases, they will be doing that genetic testing, and you should not use that NOS generic code. The reason being is that 95 to 98% of patients do have, again, a mutation. So with that, the most common histology is CML with the BCR ABL1 positive genetic testing. So that is, again, that Philadelphia chromosome. So about 95 to 98% of your cases will be this histology, 9875/3. And then we also do have a typical chronic myeloid leukemia. That would be BCR-ABL1 negative. It's rare to see this. It's only seen in about 1 to 2% of cases. And then we also do have, and that would be 9876/3. And we also have chronic myelomonocytic leukemia. That would be 9945/3. Again, this is a little bit more rare. It's a diagnosis of exclusion, and this would be seen in about 1 to 3% of your cases. CML, so we're going to take a look at the most common CML, so the CML BCR-ABL1. Again, we're going to see this in 95% or 95 to 98% of patients. The age is usually greater than 40 years old, with 45 to 55 being the average onset. We'll see this in about 15% of all adult leukemias. Risk factor, major risk factor is radiation, and CML can transform to AML. So definitely use your heme manual when you have a transformation happening to determine whether you have 1 versus 2 primaries. So again, these CMLs can very much transform into an AML, and you want to always be using your manual to determine how many primaries you have. So the symptoms, painless LAD, so lymphadenopathy, and this is usually indicative of cancer. Painful LAD is usually indicative of an infection. Fatigue, weight loss, increased sweating, hepatomegaly, abdominal pain due to splenomegaly. So 90% of CML patients do have a huge spleen. Common to see infarcts here as well due to the disease process. So in the peripheral blood, platelets usually show thrombocytosis. This is especially seen in the accelerated or the blast phase, but can also be seen in the chronic phase. A white blood cell count can range from normal at 10,000 all the way up to 600,000, which is extremely high. Blasts will be few, so you'll see few in the chronic diseases because blasts are immature blood cells and chronic leukemias are of the mature blood cells. So leukemic cells will show evidence of maturation. Basophilia, this is important. This becomes prominent as the disease progresses to the accelerated and blastic phases. And this is what tells the physicians that the patient's disease is progressing. Bone marrow, this will be hypercellular with myeloid hyperplasia. So overproduction of the myeloid cells, so the basophils, the eosinophils, and the neutrophils. So blasts, again, would be low in the marrow, as we just talked about. And the BCR-ABL1 Philadelphia chromosome would be positive with this histology. And again, this BCR-ABL1 Philadelphia chromosome actually carries a good prognosis for CML, although that is not true when we have the acute ALL. So does carry a good prognosis for CML. Definitive diagnosis, cytogenetics to detect the Philadelphia chromosome by FISH or PCR, or by RNA to detect the BCR-ABL1 fusion gene. So BCR-ABL1 or Philadelphia chromosome, that translocation between 9 and 22, those are the same genetic mutation. So we'll also, again, be looking for our bone marrow biopsy and the cytogenetics to go along with these cases to determine which particular CML the patient has. So taking a look at the phases of CML, so chronic, the chronic phase is an insidious onset, so it's slow. 85% of patients are asymptomatic or have very mild symptoms. Very few blasts would be seen, so less than 10%. Disease is usually limited to the blood, bone marrow, and spleen. Splenomegaly is very common, and the liver can also be involved. Basophilia is not yet apparent in the chronic phase. Chronic phase is usually very responsive to therapy, especially to tyrosine kinase inhibitors. Other therapies could include high-dose chemo with a donor stem cell transplant, or BRM, and or a splenectomy as well. Without treatment or refractory to treatment, patients will progress to the accelerated phase. So this is common to see splenomegaly here, as well as that basophilia becoming apparent at around 20% or more. There are also more immature cells seen here at 10 to 19%, which does indicate that this is no longer in a chronic phase. It's moving towards the blast or the crisis phase. But treatments here are still similar with the TKIs, chemo, BRM, and possible stem cell transplant. The dosing just may be different. And if the patient is not treated up until this point or doesn't respond to therapy, then they do progress into this blast phase or the blast crisis phase, where the cancer behaves more like an acute leukemia and will transform into AML in 70% of the cases and ALL in 30% of the cases. And this phase is typically refractory to treatment most of the time, and unfortunately can be the cause of death for these CML patients. So staging is the same for CML as we saw with ET and PV. The JAK2 SSDI is only collected or mostly collected for the chronic myelomonocytic leukemias, but it can be collected for any of these diseases. And as we just saw, treatments will depend on a phase of disease and include chemo, immunotherapy, and stem cell transplant. And let me just, with that SSDI, we're collecting the SSDI for all, just wanted to clarify that. But we're most commonly going to see it with this, the chronic myelomonocytic leukemias. So let's take a look at what a CML case could look like. So a 57-year-old Black male was admitted to the reporting facility for an upper respiratory infection. At this time of admission, the white blood cell count was 19,000, with the white blood cell count rising to 63,000 over 10 days. Diagnostic considerations included infectious, immune, and neoplastic causes, and a peripheral blood was ordered. So the white blood cell count was 63,000, which was high. The platelet count was 550,000, also high. Hemoglobin was 9, which is low. Hematocrit was 26%, also low. Neutrophils, so mature cells, 80%, they're high, which we'd expect to see. Myelocytes, 3%, also high. And the blasts were 1%. So this would be something that you would expect to see again. So we'd expect to see low blasts in a chronic myeloproliferative neoplasm or chronic myeloid leukemia. So that all tracks as well. Lymphocytes are 2%, eosinophils 1%, and the basophils is 1%. So this is also what we would expect to see in a chronic phase CML. So overall, the differential was a leukematoid reaction and chronic myeloproliferative disorder. They stated the BCR-ABL1 would help with differentiating which MPN the patient has. So bone marrow was also done, and this did show hypercellular, so with an increase myeloid erythroid ratio, which explains the low H&H and the high white blood count, granulocytes, and platelets. The BCR-ABL1 was positive, and the medical oncologist did state this is CML in the chronic phase. So the histology here is 9875/3. The diagnostic confirmation is 3, again, always 3 when we have those genetics there. And this patient was treated with imatinib, which is a single chemotherapy agent, code 2. Okay, we talked about the chronic neoplasms, and now we're going to take a look at the acute leukemias. So acute myeloid leukemia, or AML, so this is cancer of the myeloid lineage. and the myeloblasts specifically. Again, these are the immature myeloid cells, and acute lymphoblastic leukemia is cancer of the immature lymphoblasts in the lymphoid lineage. These are the beginning cells of the B and T lymphocytes. And in both diseases, the blasts lose their ability to become mature granulocytes or lymphocytes, but can continue to replicate and make more and more blasts or immature cells. They kind of cause a traffic jam in the marrow, affecting other cell hematopoiesis, and then they enter into the peripheral blood as immature cells. Risk factors can include previous anti-neoplastic agents for other cancers, iodizing radiation, benzenes, genetics. Some signs and symptoms can include fatigue, infections, bleeding, bone pain, multiple myeloma, or genetics. And diagnosis would be we would need an evaluation of the peripheral blood to assess the shape, size, and number of cells circulating. The bone marrow is needed to show what's happening prior to these cells leaving to circulate in the bloodstream. And cytogenetic studies are needed as well. So karyotype and molecular markers they'll be looking for possible chromosomal defects, and flow and immunophenotyping would be looking to detect surface antigen markers, or the CD. So surface antigen CD10, 19, 20, PAX5 and TDT positive are all used and helpful in identifying the lineage in these acute leukemias. So be on the lookout for those as well. So here, I see that we're still a little bit delayed. Okay, so here for treatment, per the story manual, this is really, really important. We are to record all remission-inducing or remission-maintaining therapy as first course of treatment. The administration of these therapies can span a year or more, and a lot of times they do with these diseases. So any drugs to get that patient to remission are coded as first course. It doesn't matter how many times the therapy has to change to get that patient into remission. We are to code all of those drugs, and that is all first course, or any of those types of treatment that the patient is getting, not necessarily just systemic drugs. And so a patient may have a relapse after achieving that first remission. It's at this point that all therapy administered to the patient after the relapse would be secondary or subsequent treatment. So make sure that you have note of that, and you are collecting all of the treatments that's important for these cases. So we don't want to use our rules for solid tumors that we're usually using when we have a change in a drug class, then that would be subsequent. That is not true with these leukemias, so we have to be careful with that. And getting the right treatment requires a diagnosis of that specific subtype. And why? Well, because treatment varies by subtype. So there typically will be an induction remission phase. So high-dose chemotherapy will be used, which affects all cell lines. And we usually do see pancytopenia occurring there because it's wiping the cells right out. And then they're usually given some kind of supportive care with that to help to support those new cells, new cell growth and production. There is a remission consolidation phase. So once the initial remission is achieved and cell counts normalize, additional maintenance therapy is given during that phase. And patients who qualify might also have a stem cell transplant. We're going to take a look at what those transplants could look like. And so these can be tricky to code. So both bone marrow transplant and stem cell harvest collect stem cells to replace the marrow of patients with hematopoietic cancers. And so heme transplants are procedures where first the bone marrow with the abnormal and faulty cells is destroyed by that conditioning high-dose chemotherapy. where then a rescue is needed to replace those stem cells. So new stem cells are transplanted to rebuild and regenerate new bone marrow. So let's take a look at bone marrow transplant procedures. So the bone marrow transplant, the BMT here, this procedure can retrieve stem cells from the patient or a donor. When the stem cells come from a matched donor, this is known as allogeneic transplant. If the stem cells come from the patient after other abnormal cells are kind of spun out, this is called autologous or autologous. I always get that wrong. And then when stem cells come from an identical twin, this is called syngeneic. A peripheral blood stem cell transplant, or the PBST for short, sources the stem cells from the peripheral blood of either the patient or a donor. So here, the stem cells are pushed out of the bone marrow into the peripheral blood through what's called mobilization. So look for that term, mobilization, and that's where stem cells are retrieved. Now, often in our records, we do see just stem cell transplant interchange, and it can be hard to tell, was this bone marrow, was this peripheral blood? And so when you see this mobilization term, that's an indicator that they have pushed these stem cells out of the marrow and into the bone, or excuse me, out of the marrow and into the bloodstream to be collected there. Codes 11 and 12 are only used when stem cells are collected from the bone marrow. So we have those codes there. Otherwise, we use code 20 for our stem cell, peripheral blood stem cell transplants. And there, it doesn't matter whether the stem cells came from a donor or the patient, we're still using code 20. Okay, and this next slide here shows AML histologies. And so there's histologies that are common in children, adults, and or both. And so I try to highlight with different colored font to show you, which population is most affected by this specific disease process. And so I won't go through all of these for the sake of time, but you can go through this slide on your own and read through the various types of AML histologies, who's affected, if it's aggressive, does it have a favorable prognosis, those type of things. I try to add some notes on all of these, on all of the histologies here for you. So again, we won't spend a ton of time here to go through. One note I do want to make before moving on is that AML NOS 9861/3 is usually only provisional. So really, we need to be looking for those genetic tests and seeing if we can code a more specific histology. So again, AML NOS is going to be rare to use. Look for these genetic mutations on your genetic testing reports. So we're going to take a look at what an AML case could look like. So we have a 68-year-old white male with abnormal blood work at routine PCP visit. Peripheral blood shows normocytic, normochromic anemia. So the red blood cells are normal in size and shape, but low. And monocytosis, so high monocytes and neutropenia, low neutrophils, mild thrombocytopenia, mildly low platelets, and the bone marrow shows high-grade myeloid neoplasm with prominent monocytic hyperplasia and increased blast at approximately 19%. So remember, we're typically looking for around 20% blast, give or take, indicating an acute leukemia. The marrow is hypercellular at 70% with myeloid and erythroid hypoplasia. Comment states that the differential is AML with monocytic differentiation or chronic myelomonocytic leukemia type 2 involving AML, or in that blast crisis phase. Immunophenotyping showed CD34 negative, CD33 positive, which are indicative of AML, and genetics did show an NPM1 positivity. So this case was actually AML with mutated NPM1 histology, which the code for that would be 9877/3, and the site would be C42.1. The confirmation is 3, again, because we have the positive genetics. So any of these histologies with those positive genetics should always have a confirmation of 3. This patient had the induction phase systemic therapy with 7+3 regimen, which is all chemotherapeutic agents. And then he had consolidation with HiDAC and IDIFA. He reached remission and then started conditioning therapy for stem cell transplant. And he had chemotherapeutic agents for that as well. He had an allogeneic stem cell transplant followed by maintenance IDIFA. And this patient's most recent bone marrow biopsy was normal without any evidence of AML or other malignancy. Okay, and last up is going to be ALL. So again, I put together this table to do the same, to show the various ALL histologies and to provide some information on which population this is most common to see this in, what the prognosis would look like, about how many cases, of all ALLs would be these specific histologies. So you can go ahead and take a look at this on your own. But again, I do want to point out that 9811/3, B acute lymphoblastic leukemia, is really a provisional histology. You don't want to use that unless there was absolutely no genetic testing or something, a genetic testing that maybe the patient was positive for it, but we don't have a specific histology for. So you want to be really careful with that. Most of the time, you should have one of these specific histologies. And also the other thing I'll point out too is to differentiate these BALLs, we're typically looking for a surface antigen CD 10, 19, and 20. And this last case that we're going to take a look at here today is really interesting and unusual. And so I did want to show this case. And I do want to also give a quick shout out to my colleague, Annalisa Hernandez, for helping me to pull together information in these fantastic cases to be able to share with everyone today. Okay, so looking again here at this acute lymphoblastic leukemia, very unusual. So this was a 64-year-old Black male with a 2-month history of intermittent constitutional symptoms, so fever, chills, poor appetite, and malaise. The PE was unremarkable, and there was no LAD or anything like that. The labs did show pancytopenia, prompting a peripheral blood smear. And so we did have penias again, so low, too few cells in that blood smear. And when all cell levels are low across the board, we are expecting these acute leukemias. So why is that? Well, that's because blasts and immature cells are not becoming mature cells, and they're crowding the marrow for other cells to develop. So then we have this pancytopenia. So peripheral blood showed leukopenia with neutropenia and occasional atypical blasts, anemia with anocytosis, which is abnormal red blood cells. The rouleau formation is noted, which is a stacking and clumping of those red blood cells. And there's also thrombocythemia. The bone marrow, they mentioned that they cannot reliably assess the cellularity. The myeloid and erythroid lineage is difficult to enumerate, and we would expect to see that, I guess, because the blasts are really crowding the marrow and not allowing, again, those mature cells to form. And so the numbers are really low, hence the penias. we have the megakaryocytes also here not seen, so hence thrombocytopenia. So those megakaryocytes aren't developing, pushing out, and becoming blasting out into those platelets that we would expect to see in the peripheral blood. So thrombocytopenia, okay, we would expect that. That tracks as well. Lymphocytes and plasma cells are also difficult to enumerate. Mast cells are scant and scattered. And the marrow shows that all cell types are affected and numerous blasts are seen, which indicates an acute leukemia. But now they have to determine which acute leukemia are we dealing with here. So immunohistochemistry, FISH and flow shows BCL2 and TDT positivity. So the surface antigen there, these are both detecting B cells. So now we know this is a B cell lineage acute leukemia. And surface antigen CD10, 19, and 20 also confirm this. Now they do genetics. So there's a loss of a single abnormal clone in 20% of cell with a gain of X or 2 copies, and a loss of heterozygosity of 2, 3, 4, 7p, 12, 13, 14, 15, 16, 17, and 18. Hypodiploidy defines high risk in ALL with inactivation of TP53. Low hypodiploid and near haploid tumors often undergo a doubling of the chromosome complement, resulting in hyperdiploidy population with a particular pattern as detected in this tumor. And this pattern is called masked hypodiploidy. This patient also has positive TP53, which is present in up to 93% of patients with hypodiploidy, which carries a poor clinical outcome. The managing oncologist notes that hypodiploidy BALL with less than 40 chromosomes has an extremely poor outcome and is associated with early relapse and therapy refractoriness. Notably, half of all patients with hypodiploid BALL exhibits chromosome doubling of the hypodiploid clone, which can often be the major clone at diagnosis and lead to this masked hypodiploidy. Therefore, the patient has BALL with masked hypodiploidy, and this is a specific presentation, again, of a BLL with hypodiploidy. So our primary site, again, with these cases is always C42.1. The histology is 9816/3, and the BALL with hypodiploidy would have a diagnostic confirmation of 3. The patient had induction R-mini hyper CVD and 4 cycles of intrathecal and intravenous CVD, along with immunotherapy with Rituxan. This patient did reach the initial remission that ends the induction phase and then began a maintenance phase with the POMP regimen. Of note, the patient was offered a stem cell transplant, but she did decline. That's all I have for you today. I do hope that you have some takeaways from this coding break, and hopefully it provided you a little bit of clarity in these cases that can be a little bit daunting when abstracting. Have a great day, everyone.